beginning to come out dark red. Again, the question is, if you have GI bleed, upper GI bleed, the blood is going to come out dark because it gets digested in the stomach, right? It's digested and then you excrete it. It goes through your full intestines, get digested, and then when you poop, it comes out dark. And that does have a medical term. And does anyone know what that is? Because we need to talk in medical terms like melena, right? Somebody wrote it down. Melena, dark stools. Melena, dark stools, right? Let's say the bleeding is in the last portion of the large intestine. What color would it come out? Bright red, right? So we can put here UGI. Sorry, my notes are starting to get messy, but UGI, upper GI. Upper GI, what we can do, we can start erasing some of these. Doesn't mean that they're not happening anymore, but we're getting more specific. So lower GI, bright red blood. So LGI, bright red, right? Bright red. So you get the point. Somebody said abdominal cavity. That's true. That's also going to cause issues, right? The symptoms, signs and symptoms, whether it's a upper GI, lower GI, or a bleed into the abdominal cavity. Tell me, what are you going to observe in your patient? Because it's not only about knowing where the bleeds go, that you're at a higher risk for bleeding, but how does that actually look in a person? Are they going to be just sitting there talking to you, having a conversation with you about what are their plans for the weekend, or how is that patient going to look? What is going to be their mental status like if they're losing blood into the GI or abdominal cavity? Somebody said hypotension. Very good. So low BP, hypotension. I like that you guys are talking in medical terms. Hypotension, right? Low blood pressure. And that can cascade into what? So after you're losing anemia, very good. So anemia, low hemoglobin, and low, let's see if you remember together. What is it? Low hemoglobin, low what? Hematocrit. Good. Low hematocrit. Hypertension, and then hypovolemia, hypovolemic shock, right? So now we can see the progression. What can happen with a small bleed, bruising, bleeding from the gums, bleeding from a scrape, and how it can, if you're losing too much blood and too little time, you will go into hypovolemic shock. Okay, another question. Let's say your patient cut themselves in their room and they're bleeding profusely. What is the number one thing that you're going to do to stop the bleeding? Because again, you need to know what your nursing intervention is going to do. What do? Apply pressure, right? Apply pressure. That's going to be your number one intervention to stop the bleeding. Okay, so we've talked about, let me see what I can do with the theme. Okay. So that's how we want to start, right? That's how we want to study our anticoagulants. So now you have a very good idea. If I tell you, let's start with heparin. If we start with heparin, you already know. What are the side effects of heparin? Now you know. Now you know what's going to happen. What are you using it for? What are you trying to prevent? And what are going to be the side effects of it? So just let me open your ATI book that I have right here. And this is available to you. You can access it in your ATI ebooks. This is chapter 25 if you want to go after and you want to read the whole thing. I'm just going to go briefly through it. And it says here that we have our class, right? Anticoagulants, they're going to affect clotting factors. And how many clotting factors do we have? That's a good place to start. How many clotting factors are there?
4.
It's more than 4. It is 12 clotting factors. And as you will learn in hematology, you'll learn your disease processes. Some disease processes affect only one clotting factor. Others affect multiples. And the medications similarly work either on 1 or 2 or even 3 clotting factors. So we're going to start with heparin, right? That's what we're talking about here. And then we have our low molecular weight heparins, which is enoxaparin. And they're being bundled together because they are similar, right? They do similar action and they have a similar. So here it is, activated factor XA inhibitor. So this is talking about a clotting factor, and it is X Roman numeral is for 10, right? So it's going to inhibit clotting factor 10A. That's what it's doing. So you have the 3 heparins, low molecular weight heparins, and you have your activator factor 10A inhibitor, which is fondaparinux. So those are your 3 medications that you can classify under heparins. So here it is. Heparin prevents clotting by activating antithrombin. Thus indirectly inactivating both thrombin and factor 10A. Is thrombin a clotting factor? That's a good question right there, because if you don't know what thrombin is, then you really don't understand what these medications are doing. So is thrombin a clotting factor? Yes, right? Thrombin is a clotting factor. I'm going to show you a list of clotting factors. And again, it's not to intimidate you or anything. It's just so that you're aware how many clotting factors there are and what are the names. You have Dr. Google, right? You can ask Dr. Google what your clotting factors are. Of course, you want to get it from a primary source like your book. But if you're short on time and you're just doing a quick review, then we can also ask Dr. Google, and in this case is Dr. Bing. But you can see here, you have your factor 1, which is fibrinogen. So have you ever heard of fibrinogen? That's factor 1, prothrombin. That's factor 2, or thrombin. Factor 3, or tissue factor, and then you have again 4, 5, 6, 7, 8, 9, 10, 10A, 10B, 11, 12, right? So those are your 12 clotting factors. And again, each medication is going to be affecting different one of these. So let's go back to the book. So heparin affects thrombin, which is factor 2 and factor 10, right? It inhibits the fibrin formation. So You need fibrin to make clots. So if you're interrupting that process of clotting, then you're not going to get a clot. Question, can heparin, we know that heparin prevents the formation of blood clots, but can heparin break down clots? Let's see what you guys are saying in the chat. I got 4 no's. So yeah, heparin does not break down clots, right? We are not going to talk about, well, we can touch on it briefly. Again, this is a review, right? This is to help you get a full understanding of how clotting factors and anticoagulants work. Does anyone know which medication actually breaks down clots? Thrombolytics is a category of medications. Give me one that's in there, the most common one. TPA, right? TPA, alteplase, streptokinase. That one you give to break up a clot. So again, we're not talking specifically about that one, but again, we want to get a full picture of something that actually breaks down the clots. So it says here heparin stops. It says here that we use it for clients having open surgery or dialysis, or they're having a valve placement, or we're trying to prevent a stroke, we're trying to prevent a pulmonary embolism. There is one thing that we actually, I guess we could say forgot. You told me that blood clots can cause strokes. You told me that blood clots can cause PEs. And you told me that blood clots can cause DVTs. But blood clots can also cause one more issue. Okay, somebody said Eliquis. Eliquis does not break down clots as far as I'm aware. But the other thing that we're missing is myocardial infarctions. Do not overlook that one. Blood clots can also cause myocardial infarctions. Low dose therapy for prophylaxis against post-op venous thrombosis and treatment of DIC. We're going to touch briefly on DIC. And DIC is disseminated intravascular coagulation, right? So in this case, in DIC, your body becomes, it's a cascade of the clotting in your body, and that's how you could throw multiple clots in DIC, even though if you have low platelets. So that's what I want to say about that. Let's go back to your book and see what else it's telling us. So that's what we need to say about DIC. Learn more on that if you're still not sure what's going on. I'm showing you that screen. Thank you. All right. Mr. Harry, you just told me I'm not sharing my screen, so there you go. We're going to correct that. Okay, so this is where I'm getting this from. So I'm sorry you weren't able to see this. I'm just going to change my share mode because it's when I'm using the whiteboard. It's more difficult to share multiple things at a time, but I'm going back to just sharing the full screen. So you could see when we go back to whiteboard, then it'll stop sharing the screen. All right, so I'm actually pulling everything that I'm talking about. I'm getting it right from your chapter 25 in your ATI book. So that's where I'm getting this information. So here's what I was talking about: heparins, low molecular heparins, and activated factor 10A inhibitor, and the expected pharmacological action. I was summarizing it from here. What we must know for heparin, it does have an antidote. So if you give somebody too much or it accumulates too much in their blood, we do have a agent to reverse it. Does anyone know what that agent is? What do we use to reverse heparin? And it says right there, protamine sulfate. Somebody said K. what do you guys think Edgar meant by K? What is he talking about? What's a K? So somebody's saying warfarin, somebody's saying vitamin K. So let's make sense of this. K is vitamin K. That is correct. And protein. So let's one step at a time. So protamine sulfate is the antidote for heparin. Right. Write that down. Protamine sulfate is the antidote for heparin. And the antidote for warfarin or Coumadin is vitamin K. What you need to memorize is the other names for vitamin K, because that's where you will encounter issues in your exams because you don't know the other names for vitamin K. Does anyone know other names for vitamin K? One of them is going to be aquamephetone. Aquamephetone. So let me put it in there so you can write it down. Is AQA. Aquamephetone is the first one right there. Aquamephetone. It's a vitamin K anticoagulant reversal agent for the treatment of coagulation disorders. So you could think of it as the brand name if you want to. I mean, it is the brand name. So brand name of vitamin K is aquamephetone. And the other name is that should be in here is phytonadione, right? That's what it is. That's the other name for vitamin K. So these are your two names that you didn't know. Now you have three different names for the same thing. If you didn't have enough things to memorize, now you get to memorize three names for the same thing. Question: why do we give newborns vitamin K or aquamephetone injectable when they are born? You got a newborn and we're giving them vitamin K. They're not on Coumadin. Why are we giving? Melissa said they don't have it naturally because they don't have enough when they are born. I like those explanations, yes. And they can bleed out, right? They can have a brain bleed from the trauma of childbirth. They can have an intraventricular hemorrhage inside of the brain, right? So we want them to prevent them from bleeding in their brain or bleeding internally. Same concepts of an adult that they can bleed internally, right? Into the abdominal cavity. But more than likely, we're trying to prevent a brain bleed because if the baby has a brain bleed, it's kind of getting a hard difficulty at the beginning of your life, right? You're going to be having a lot of sequelas from having a brain bleed and a lot of follow-ups that you have to go through. Okay, so we're talking about heparin. Let's go back to your book. It says protamine should be administered slowly, IV, no faster than 20 milligrams per minute or 50 milligrams in 10 minutes. Do not exceed 100 milligrams in a 2-hour period. We talked about hemorrhage. You told me that you could develop hypovolemia, so that's why you're looking at those vital signs, because if the blood pressure goes down, what's going to happen to the heart rate? It says right here, right? Increased heart rate. Blood pressure goes down, heart rate goes up. Decreased blood pressure, there it is. Brucine, petechiae, hematomas, black tartar stools. And it says here that for heparin, you need to keep an eye on the lab APTT, activated partial thromboplastin time. And the value must stay from 1.5 to 2 times the baseline. What happens if it is not? What's the risk if it's under 1.5? It is not therapeutic, that is true. But again, we were talking about the intended use and the side effects. So if you don't have enough in your bloodstream of it, what's going to happen? You're going to clot, right? You're going to throw clots. And if you have too much, if it's above 2 times the baseline, what's going to happen? Bleed out, right? Same things, same concepts that we talked about, internal bleeding, external bleeding, etc., etc. All right, epidural or spinal hematoma. In which situations could this happen? Epidural anesthesia, right? Or they're gonna do a spinal tap. So we need to look at their clotting times, right? Before you're gonna do any of these procedures, you're gonna check those clotting times, make sure that they're not elevated or that they're normal. Again, depending on the situation of the patient, right? Heparin-induced thrombocytopenia, so it's a low platelet caused by the heparin. So again, you're going to be looking at that platelet count, and you're going to stop the heparin if the platelet count is less than 100,000. Hypersensitivity reactions, chills, fever, or tachycardia, that's basically another allergy to the medication. You have enoxaparin, another anticoagulant, hemorrhage, same thing, right? Vitals, platelet count. Education, watch out for signs and symptoms of bleeding. Avoid aspirin. Should you avoid aspirin with all anticoagulants? Somebody said yes. Anyone else? Do you guys all come to the same consensus that you shouldn't take aspirin if you're taking anticoagulants? Okay, so another person said yes. What about vitamin K? NSAIDs? Oh, nice. You're bringing up NSAIDs. What about vitamin K? Should they be taking supplements with a lot of vitamin K if they're supposed to be taking anticoagulants? Whether it's Coumadin or heparin? No, right? Because again, you're defeating the purpose of the medication. You're increasing your chances of throwing a flat. I'm going to say for the avoid aspirin, yes, for most of them, right? You want to avoid it. But could the physician prescribe Coumadin and aspirin daily? Yes, he could, right? Depending on what the cardiologist determines that, a lot of these cardiac patients are going to be on 325 milligrams of aspirin daily. It says neurologic damage from the hematoma formed during spinal or epidural anesthesia. Spinal tap, epidural anesthesia, I just mentioned that. How do you think the nerve damage occurs? What happened? What happened? Feel free to unmute yourself and explain. But what happened in that case? How does the hematoma cause nerve damage?
Maybe it's pressing up against the nerve.
That's exactly what's going on. That's exactly what's going on. There's a bleeding inside of that cavity, and blood is very viscous. It takes a lot of space, and yes, it does definitely press on those nerves in it. So that's why you're always watching for the hematoma formation, redness, swelling, and sensation of the lower extremities. Because again, as that nerves or those nerves start getting pressed, then you're going to have those neurological deficits. And then it says here, heparin-induced mediated thrombocytopenia. We talked about that too. Same thing, right? Monitor, stop if the platelets are less than 100,000. Toxicity, protamine sulfate. We talked about that, and is repeating you the same thing in the top. Here's that fondaparinux that only works on the 10A clotting factor, but what are the nursing actions? Same thing, right? You're monitoring for bleeding, vital signs, blood pressure, heart rate, platelet count. Avoid aspirin. Same thing, neurologic damage from hematoma during spinal. So you can start seeing the pattern, right? They're all going to have the same side effects, and they can all do the same thing. Whereas if you just try to memorize each individual one and you don't know what they're doing, then again, you're going to have a hard time answering these questions. It says here heparin is a pregnancy category C, enoxaparin, dalteparin, and fondaparin are category B. So that's for pregnancy indications. Contraindicated and low platelet counts, we said we stop it under 100,000. Should not be used during or following surgeries of the eyes, spinal cords, lumbar puncture, or regional anesthesia. Use cautiously in patients who have hemophilia. Okay, I'm gonna make a stop here. Why do your patients have orders for heparin and Coumadin at the same time while they're in the hospital? Let's say your patient had a heart valve replacement. Why are they?
Warfarin takes longer for therapeutic effect.
Excellent. So yes, the Coumadin is going to take longer to take effect, and the heparin is for an acute care, right, to prevent clotting formation. So as they're getting the patient to get discharged, they're going to wean him off of the heparin and then make sure that that Coumadin is at the right therapeutic level, and then they'll discharge him. Very good. It says interactions. Somebody mentioned NSAIDs, so we're definitely going to talk about that. Anybody heard about COX-1 and COX-2? Anybody heard about that? No? Okay. Let's see. Let's ask Dr. Ming. All right, this is what Dr. Bing has to tell us about COX-1 and COX-2. It says COX-1 and COX-2 are two types of COX enzymes that produce prostaglandins. COX-1 is present in most tissues and produces prostaglandins that help maintain the gastric mucosa integrity and platelet-initiated blood clotting. Why am I bringing this up with NSAIDs? Because a lot of these NSAIDs interrupt the function of COX-1 and COX-2. And they actually do have medications that are COX-1 or COX-2 inhibitors, which specifically target clotting from those enzymes. So that's what that is. That's why somebody said NSAIDs. And if you didn't know it, now you know it. And that's why NSAIDs can also cause bleeding, because that's why we don't want any of these patients to take any of these anticoagulants and be taking NSAIDs at the same time. Can they still take it? Maybe the physician will prescribe it, right? It's not your call, but you always want to double check with your physician. Hey, I noticed you have him on heparin and Coumadin and they're taking aspirin, and you also have him on ibuprofen 600 milligrams. Then you want to check, right? You want to ask, hey, is this appropriate? Because I know that NSAIDs also interrupt with clotting because they increase the risk of bleeding. Resveratrol and saw palmetto, which is a herbal supplement, can also have an antiplatelet effect. So you always, again, want to avoid concurrent use, meaning if they're taking anticoagulants and then taking NSAIDs and aspirin, you want to double, triple check. Garlic, ginger, glucosamine, or ginkgo biloba, which are also supplements that people usually take that buy at the supplement store, can also increase the risk of bleeding. So see, these medications have an increased risk for bleeding and monitor for bleeding. How are we going with time? Wow, we're almost done with the first hour. Again, baseline vitals, APTT, read your labels carefully, check your dosages with another nurse before giving it. Use an infusion pump for continuous IV administration. Administer deep sub-Q injections in the abdomen. Rotate your sides. Use a 20 to 22 gauge needle. Gentle pressure for 1 to 2 minutes after the injection. Rotate and report injection sites. And advise the client to use an electric razor for shaving and to brush with a soft toothbrush to prevent the gum bleeding. You as a nurse, or you want to educate your patient, you to report if they're having coffee ground emesis or calorie stools. Avoid the use of over-the-counter NSAIDs. We just discussed why, right? Aspirins or medications containing salicylates. They do have a combo. Let's see, monitoring is not required. They're acceptable for home use. However, tell me, just because it says right there monitoring is not required, does that absolve you of checking anything on your patients? Is that a pass for you not to check? No, yes, maybe. So no, right? That is not going to give you a pass for you. It says it's just supposed to work better, right? These combo drugs, they are acceptable for home use, but you as a nurse will not be absolved, right, of doing your work, making sure that your patient isn't bleeding out and having any complications and interactions from the use of these medications. So you want to provide instructions regarding self-administrations. Medications are available in pre-filled syringes. Pre-filled syringes are available in various dosages, and again, it's just repeating the same stuff, right? Rotate sides, don't rub the side. And again, you can read this, but you can see, right, how these medication classes have these recurring themes of the same warnings. Use an electric razor for shaving, same thing, and brush with a soft toothbrush. All right, so it says here that how do we know the medication is working? APTT levels of 60 to 80 seconds are in treatment. So what we need to know is, do we even know what a normal APTT is? If we don't know what a normal APTT is, then how are we going to know that they are in a range of 1.5 to 2 times the range, right, of what they're supposed to be at of a normal APTT? So here we go. Vitamin K inhibitors are coumarins or coumadins, warfarins. I think we should stop here. We're going to go to a little case study that I prepared for you that is related to anticoagulant therapy. Let me pull it up and we're going to start. All right, so it says here that Sarah is a 65-year-old female. She has a history of atrial fibrillation, a common heart rhythm disorder that increases the risk of stroke due to the formation of blood clots. It says here she presents to the cardiologist with a diagnosis of AFib confirmed with an EKG, and she has an increase of risk of stroke. The cardiologist initiates her an anticoagulant therapy with heparin to prevent blood clot formation. So let me ask you, question number one, why is she at a greater risk for stroke? What's going on there? Yes, we know she has atrial fibrillation, but what is happening in the disease process, in the pathophysiology that is placing her at a greater risk for the stroke? The heart is beating irregularly, giving it the chance to create a clot. That's true, but where and how? What part of the heart is beating irregularly, and why is it getting a chance to clot? So let me pull up a small video on AFib, and then we will observe that we have the issues in AFib is because the atrias, right? It's in the name, atrial fibrillation. The atrias are fibrillating, they're allowing blood to pool, and that is giving enough time for clots to form. And then, excuse me, we're gonna have those 4 complications of blood clotting that you described, right? PE, stroke, MI, and DVT. do we, since she's, let me ask you this, is heparin appropriate for a person with AFib to be taking for the management of the prevention of clot formation? Is that the standard treatment? Is that what you usually use for someone that has AFib? No, right? We don't use that as a normal usual treatment. What is a usual medication that is used for AFib? And we were moving into that category, right? So what is it? So here's a minute, warfarin, yes, Coumadin for long term, that's what we use. And again, here's a minute video just showcasing what's going on and how you form clots.
Your heart is made up of two parts.
So yes, you guys don't hear the audio. Oh, I'm really sorry. Anyways, it's just showing, I'm sorry you don't hear it, but the point is just that the heart, you can see how the atrias are just misfiring, right? The atrias are misfiring, and that causes the blood to pool, and that is what causes the clots to form, and that's what's going to cause the complications that are associated with atrial fibrillation. But good catch. So again, this is a case study, so yes, a physician will not prescribe heparin for atrial fibrillation. However, there is something else going on in this case. So that's when she showed up. So she started initially on heparin to quickly achieve therapeutic anticoagulation. Because let's say they're diagnosing her, right? She's in the hospital for the first time, and we want to make sure she doesn't throw a clot. And like you just told me, the Coumadin is going to take time to work, right? It's not going to work right away. It's going to take a couple of weeks to become activated and actually go into therapeutic mode to protect the patient. However, it says that because of the persistent nature of Sarah's atrial fibrillation, or maybe she's having supraventricular tachycardia, her cardiologist recommends electrical cardioversion to restore a normal heart rhythm. Sarah is provided with information about the procedure, its risks and benefits. It says here, anticoagulant transition, where we discussed. In preparation for the cardioversion, Sarah's anticoagulation is carefully managed with heparin, and the healthcare team is monitoring her clotting factors. So I added this here for you to make sure you knew what each one was. So APPT that we were learning for heparin, right? It says activated partial thromboplastin time is a test that assesses the time it takes for a blood to clot. It's commonly used to monitor heparin therapy, and the therapeutic range may vary. But it's not going to vary for you, right? we do have clear values that ATI gives you, and you should learn this. So I'm just putting these for reference here. PTA test that measures the time for a blood to clot, and again, depending on the lab, it might change. And then INR is a measure of the PT, ensuring consistency across different laboratories. This one, we do have a target range of 2 to 3 for Coumadin, right? So now you know. Post cardioversion anticoagulation. So she was successfully cardioverted. She was transitioned to an oral anticoagulant, warfarin. And here we have her lab, so we can have an idea. So before cardioversion on heparin, we have a PT of 14 seconds. Normal range was 11 to 13. The INR was 1.2. So that's not applicable for heparin. Activated partial thromboplastin time was 40 seconds. Normal range is 25 to 35. And then post-cardioversion, before they were ready to discharge her, they changed her to oral Coumadin. And here we can see our lab values. She was on 18 seconds for PT. INR was 2.5 and APTT was 32. And then she was stable on warfarin, and then she of course has to follow up with her cardiologist. We have to keep monitoring her heart rhythms. And the question here is, well, it says it right there, right? It can come back, right? It can always come back. There's also antiarrhythmic medications that this patient will be taking. I won't go into those because it's outside of the scope of this review, but that's what she's taking. And then again, follow up with cardiologist. So again, PTINR for Coumadin, PTT, APTT is for heparin. All right, so let's go back to our review. Okay, so we finished anticoagulants. I think I was gonna go into, let me look at your book. Okay, it's gonna tell us about Coumadin. We're just gonna finish Coumadin and then we move on to chemotherapy and cancer. All right, so it says here vitamin K inhibitors. We said vitamin K has other names. The brand name for vitamin K is acomefeton and phytonadione. Even I have a hard time remembering that one. Phytonadione. Expected pharmacological action for coumarins or coumadins. It antagonizes vitamin K, thereby preventing the synthesis of 4 coagulation factors. So maybe that's where that person was saying that we have only 4 coagulation factors. That's probably where they got this. But now it's 12. But if you're interrupting the creation or the formation of 4 of them, then you're gonna have a harder time clotting, right? So yes, it prevents DVT, PE, MI, stroke. It's prevention of thrombotic events for clients who have AFib. We discussed that. Or heart valves, reduction for the risk of transient ischemic attacks or myocardial infarction. So transient ischemic attacks, your mini strokes, right? Like mini strokes that you get. And they can come and go. They're temporary. Complications, hemorrhage, we already discussed that. It's again going to be vital signs, low blood pressure, increased heart rate. Look at your labs, and if they are going into Coumadin toxicity, you want to stop it and administer vitamin K. Hepatitis, also monitor liver enzymes, assess for jaundice, toxicity. Administer vitamin K to promote synthesis of coagulation factors 7, 9, 10, and prothrombin or 2. This is how you administer IV vitamin K. If vitamin K cannot control bleeding, administer fresh frozen plasma or whole blood. Why? Why? What does fresh frozen plasma have and whole blood have that prevents bleeding or controls bleeding? What does it have? What does it contain that it will prevent bleeding?
Platelets.
Platelets, right? Yes, very good. It contains platelets, so that's going to help you with clotting. Contraindications: warfarin is a pregnancy risk D, category X, due to high risk of fetal hemorrhage, fetal death, and central nervous defects, so they shouldn't be taking Coumadin if they're pregnant. Don't breastfeed because it gets passed. Don't take it if you have low platelet counts, same as the other one. No, don't take it if you're gonna have a surgery of the eye, brain, or spinal cord, lumbar puncture, or anesthesia, same as the other anticoagulants. Contraindicated in vitamin K deficiencies and used cautiously in clients who have hemophilia, dissecting aneurysm, peptic ulcer disease, severe hypertension, or threatened abortion. Again, bigger risk of bleeding out and dying. Hypovolemic shock. Same thing. Don't use it with heparin, aspirin, Tylenol, glucocorticoids, sulfas, and cephalosporins because they increase the effect of the warfarin. So they potentiate the effect of the warfarin. So just what I told you, observe the inclusion of aspirin and OTC medications or whatever they're taking. It's your responsibility as a nurse to know what they're taking and making sure that it doesn't get activated. Concurrent use of phenobarbital, carbamazepine, dilantin, oral contraceptives, and vitamin K decreases anticoagulant effect. Meaning, if you are using these things, are you going to require more medicine or less medicine to achieve a therapeutic range? If you're taking any of these things, are you going to require more medication for it to be effective or less medication for more medication, right? You're going to require more medication and the physician has to address that. Why are oral contraceptives being included in here? What's going on there? What are oral contraceptives associated with? Blood clots, right? It puts you at a higher risk for clotting. So yes, stroke. Same thing if you're using anticoagulants. If you're using oral contraceptives, don't smoke. You're placing yourself at a higher risk for clots. You should educate them about foods high in vitamin K, like dark green leafy vegetables, Brussels sprouts, mayonnaise, canola, and soybean oil, because it's the antidote for the medication, so therefore you're going against the medication working. Resveratrol and sulfamethyl increase the risk of bleeding. Coenzyme Q10 decreases Coumadin's effectiveness. Feverfew, garlic, ginger, glucosamine, and ginkgo biloba increase the risk of bleeding. Multiple other medications interact with warfarin. So if you don't know what's going on with your patient and you think it might be the medications, it might be the Coumadin interacting with something else. All right, all of this stuff is going to be the same, right, for anticoagulants. So I'm just going to go, let's see, dabigatran. So you're going to have argatroban and dabigatran, and these are going to be direct thrombin inhibitors. See, here it is, argatroban. So see, let's see if you are retaining any of this information. Thrombin is which clotting factor number? Prothrombin, thrombin. And if you don't know, you did know. Good. Number 2. Yes, it's number 2. So what do we expect of these? Binding with and inhibiting thrombin, thus preventing a thrombus from developing. Dabigatran prevents strokes. It's for AFib usually used. And argatrobin is used for those that cannot take heparin due to heparin-induced thrombocytopenia. So that's kind of what I want to exalt to you of those two. Complications, bleeding, GI, same stuff. So we're gonna move on to chemotherapeutic agents since that was actually quite lengthy. So we're gonna go back to the whiteboard. Take a quick 10 while I pull up the stuff. So take a quick 10. I'll be back in 10 minutes.